Good evening to you. Hi, I'm Pastor Mike Eastup here from Suncrest, and we thank you for being with us this evening in person. And there are a number of folks who are joining us online, and we welcome you among us as well. These are strange days to be alive, and we have lots to think about because we have responsibilities for people and our neighbors, co-workers, fellow church members, communities, and so we're here to learn as much as we can so that we can be the kind of good neighbor that we want to be. We're so grateful for Dr. Chris Martin and Angel Smothers and for helping provide it this evening, the School of Nursing, Health Sciences. So grateful. You are in a sanctuary, and that means you're a captive audience for a preacher to pray. So I would invite you, if you wish, to join me in prayer. Our God, our eternal God, it's a strange day to be alive. We recognize that across the ages, your people have faced similar things and have come through it and learned from their experiences. We know that there are many people whose passion has been to learn, to study, to research, and to prepare for days like this. And we are grateful that we both have people from across the ages and people who right now are ready to help us to learn and to care for one another. We do pray that the wisdom that has been provided would be applied not only in what we do, but especially in those who lead us on bigger stages. That the wisdom that we know would be applied to our communities. We would offer this prayer in the name of Jesus, who in his incarnation chose a life as vulnerable as ours. Amen. All right, without further ado, well, first let me say this. If you're visiting with us and you need to visit a restroom or find something like that, exit the sanctuary, take a left down the hall, and you will find what you need. Also, if you need a bottle of water or something to drink, the School of Nursing has provided some of that right outside, and you're welcome to bring that back in here if you need to do that. Okay, Dr. Martin?
All right. Well, thank you very much. My name, again, is Chris Martin. I am a physician by training, but I'm a strange physician because I'm not in the School of Medicine. I'm in the School of Public Health. So as a public health physician, that's going to be the emphasis of my lecture this afternoon. And I love knowledge. I love data. The pastor mentioned the wisdom. I think with knowledge, we can get through this together. And so it's my hope this evening to provide you some of the knowledge that you need. Again, I'm going to focus on some broad principles that relate to how infectious diseases behave generally and illustrate them with what's going on now with the current outbreak. So, without further ado, is it possible to dim the overhead lights? I don't know if... No? Okay, I'm getting a no. But one of the great things that we have today is incredible knowledge that we can access very rapidly. And if you haven't seen this, this is from Johns Hopkins Bloomberg School of Public Health. Yes, that's the same Bloomberg that's very famous to all of you. And they are tracking on a continuous basis the current epidemiology or all the data as to how this disease is spreading in the population. So this was the status as of 2:35 this afternoon. So you're getting latest data. Globally, 127,000 cases Total deaths, 4718. Total recovered, you can see 68,310. And at the bottom graph, you can see in orange the cases in China, which, as you can see, are plateauing. This is the bottom right corner. Green are recovered cases, so a lot of people, most people recover from this infection. And then yellow cases are the new cases that are accruing outside of China. So in essence, China seems to have maybe reached a plateau, maybe the worst is over for China, but you can see explosive increase in countries out of China. And it's hard to discern the countries listing, but particularly Iran, Italy, South Korea are three of the countries that are experiencing enormous increases currently. So you can watch this and see how it's displayed. It's now affecting every continent in the country except Antarctica. So what I'm going to do today is I think in terms of who, what, where, when, I couldn't come up with too many who's for this, or other than the World Health Organization. But we're going to talk about where this started, how this all began, because I think we should not lose sight of how this started. As a public health physician, I teach the medical students that the most important prevention is primary prevention. Don't let it start in the first place, okay? We always lose sight of that. So we have to understand its origins, and as it turns out, this virus has followed a pattern very similar to other viruses. What is coronavirus? It's interesting when I get on Google and I start Googling corona, you get a lot of interesting unrelated hits. But talk about the nomenclature, and I'm a very strict person when it comes to terminology. I think we have to use words correctly, and so I'm going to try and clear up some of the confusion in terminology and concepts. A question that's on everybody's mind: how serious is this infection? What can I expect? How does it spread? And what can we do to prevent that spread? And I'm going to think about that in terms of the individual level. What can a single person do? And then as a public health physician, when I think of groups of people, what can we do at the level of population? And how do you understand the strategies there? We'll talk about things like quarantine and isolation. And since I'm in a sanctuary, I will even quote scripture. The pastor should hopefully be pleased. There will be scripture quoted, which is whenever I give similar lectures on infectious disease epidemiology, I quote scripture, and you'll understand why. And then another question on everybody's mind, probably after the how serious is it, when can we expect treatment or vaccination to be available? Okay? And there'll be time for questions at the end. I hope I've anticipated a lot of the common questions, so if you don't mind waiting till the end, then I'm happy to stay for as long as needed to answer questions. So before we plunge in, two important caveats. This is a novel or new viral infection in humans, and so there is a lot that we do not know. However, it's not the first in this category of viruses to cause this problem. It's actually the third. So we're going to talk about two of the previous similar viruses and what we can learn that may be applicable to the current pandemic, and it is now a pandemic. And the situation is unfolding so rapidly. I heard people talking, March Madness is canceled, Disney's theme park it's all-consuming. When you go to the news websites, it's nothing but coronavirus, and the situation is changing rapidly. So that data that I showed you from Johns Hopkins, it's all out of date. Okay? It's probably out of date by the time they post it. So the situation is unfolding very rapidly. So a lot of this is tentative. Next slide, please. So where did this start? Next slide, please. As you probably know, this started in the city of Wuhan in China. I, as a global person, have traveled a lot. I've been to China many, many times. Wuhan is in central China. It's on the Yangtze River, and it is a city of 11 million people. So when we have visitors from China, they'll often say to us, "We come from a very small town." And I'll say, "What's the population of your small town?" They say, "It's only 3 million people." Okay, so that, and unless you've been to China, it's very difficult for you to appreciate just how densely populated it is. Everywhere is crowded, and that's going to turn out to be very important for understanding this disease. It's 11 million people. approximately 1 million people go in and out of Wuhan every day when it's operating normally. 1 million people in and out. The best description I heard of Wuhan is it is the Chicago of China. Okay, so big trading center. It's on the Yangtze River. There's a lot of rail lines, a lot of road lines, a lot of people going in and out of that city, which is relevant to this outbreak. Next slide, please. As you probably know, this started in a particular market. It was the Huanan seafood wholesale market, also called a wet market. Again, you have to understand China to understand what this is all about. This is a place that, as you can see in the pictures, sells both meat that we would go to a grocery store and buy, but also lots and lots of live fish, live animals, live snakes that are prepared to order. Okay? And I was very impressed when I saw this sign, that this is a sign of the pricing of what you can buy at such a market. And you can see your vision is not betraying you. Yes, that is a peacock. There's a picture of a dog. There's a camel in the upper right-hand corner. A huge variety of unusual animals. What's circled there is tree bear. In Chinese, that often refers to a koala. So, if you feel like eating koala, you could potentially have koala. So the point is, a very wide variety of animals are consumed in traditional Chinese diet. Many of them are wild animals, and that is very important to this story as well. Note also a very high density of people. So you have a lot of people and a lot of live and dead animals in very close quarters, and the early cases are thought to have arisen in this market in December of 2019. Next slide, please. So this is a very cute-looking animal. It seems to be a blonde bat. I didn't know we had blonde bats. Maybe it's just the exposure. But this is the horseshoe bat, the Chinese horseshoe bat, and this is considered to be the source of the current pandemic that we're experiencing. We know that based on genetic studies. So there is a virus in bats that is virtually identical to the one that is circulating in human beings. Now, bats are not particularly active in December, so they're hibernating. Although with our strange winter, we had one fly in our backyard just a couple of weeks ago, but generally they're not particularly active in winter. Nor was there any evidence that bats were in the seafood market that I mentioned earlier. So this has led to the idea, which is very common in these outbreaks of disease, that it has an animal reservoir, it moves to an intermediate host, and then goes to human beings. In this case, we don't know what that intermediate host was. Some speculation about another mammal called a pangolin, which is the most traded animal in the world. Unfortunately, when the outbreak occurred, the Chinese moved in very rapidly, incinerated every animal alive and dead in the wet market, and destroyed everything. So we don't know what the intermediate host was in this case. So probably started with a bat, came to some other animal that was in this market, and the early cases all acquired it from contact with that intermediate host. And this is not at all uncommon. If this sounds like a strange scenario to you, it is not. Almost 50% of emerging infections in human beings arise in animals in this way. HIV arose that way, Ebola arose that way, many, many diseases arise like this. So, what is coronavirus? Here, I'm a stickler for terminology. I'm also a stickler for spelling. Both tend to be irritating to those around you, but the correct terminology, which is not often used, is that the virus, the correct terminology for the virus is severe acute respiratory syndrome coronavirus 2, SARS-CoV-2. As we'll see, it's not the first. There was one prior to it, and another closely related coronavirus infection as well. The disease it causes is called coronavirus disease 2019, or COVID-19. So some people think that this is the 19th disease. No, it's not. It's just the year that it was recognized in December of 2019. And so the term coronavirus is a family of viruses. So if you just say coronavirus, it's not particularly specific. And so that's a term that I would discourage you using, because it's not really, at least in a healthcare setting, it doesn't really tell us much information. It's like saying, I have a pet animal, right? It doesn't really tell me what kind of pet you have, all right? And it's called coronaviruses because, as you can see in the electron micrograph, you see those green spikes around it. When it was first being observed, people thought that these spikes, which are proteins around the outer layer of the virus, that these looked like a crown. So hence the term coronavirus from the word for crown. Next slide. And it is a large family of single-stranded RNA viruses that some infect animals, some infect humans. And just so you understand, the flu virus is a completely unrelated family of viruses. So it appears as if this infection has some shared features with influenza, but in other ways is very different. And genetically, it's a totally different family of viruses. 4 types of coronaviruses we've known since the 1960s circulate in humans all the time. They've been with us for a long time, and they are the second most common cause of the good old common cold. Rhinoviruses being the first cause. So we've known since the 1960s by checking people who have a common cold that coronavirus causes it. At least we assume it causes it. Very, very, very rarely, and so rarely that I would write a paper into a medical journal if I saw it, it can cause more severe disease in healthy people. But sometimes in immunocompromised, very, very rarely in otherwise healthy individuals, can these well-recognized 4 types of coronavirus with very, impossible to remember names, 229E, NL63, etc., cause common cold minor symptoms that will not kill you. And these follow a seasonal pattern, these coronaviruses that cause common cold in humans. Okay? So a lot of speculation is this current pandemic going to die down when we hit the summer months? The answer is we don't know, but if it behaves like these other coronaviruses that cause common cold type symptoms, it might. Okay? Next slide. Then there are 3 other types of coronavirus that are so-called zoonotic diseases, or zoonoses. This is a term that refers to an infectious agent that's normally present in a vertebrate animal, like a bat, but jumps into a human. And I mentioned that this is not at all uncommon. Many emerging infections in humans originated as a zoonosis. So there are 3 that are in animals that can jump to humans. They are SARS-CoV-2, the one that we're all concerned about now, described in 2019. Mortality data we'll talk about, but 3% or less is current mortality. I'll get into more depth about that. That's SARS-CoV-2. The second is the Middle East Respiratory Syndrome, or MERS-CoV, that was identified in 2012. That is endemic or always present in the Arabian Peninsula, mostly Saudi Arabia, and it is an infection of dromedary camels. We have a daughter, 10-year-old daughter, Alice the camel. This is Alice the camel has 1 hump. This is one of those 1-hump camels versus the 2-humped Asian camel. Okay, so it's in camels. It infects humans regularly in this part of the world. And occasionally we've had secondary transmission, usually in a healthcare setting. This one is it's much more serious than the other 2 types. Mortality for this one approaches 1/3. So about 1/3 of people who get this infection die. Okay? But it's a different virus. It hasn't really been a problem outside of the Arabian Peninsula. But as I mentioned, sometimes someone comes back from Saudi Arabia, gets very sick, goes to a hospital. If the hospital doesn't follow appropriate protections, there have been transmission to healthcare workers. And one country that had a huge problem with that was a hospital in South Korea several years ago. Again, that's going to become relevant to our story. And then there's another one. I'm originally from Canada, and if you were in Canada, you remember the SARS-CoV-1 outbreak. So this was the first outbreak versus the second one now that we're dealing with, SARS-CoV-2. In 2002, 2003, there was an epidemic of this virus, particularly hit Toronto badly. One person flew from Singapore to Toronto. But again, much like MERS, most of this was secondary transmission to healthcare workers. There wasn't a lot of spread beyond the healthcare setting. But again, you're going to hear me refer to these because as we think about the current pandemic, I'm going to draw upon our experience with these two related viruses in the same family to teach us some lessons. For SARS-CoV, we do not know the animal reservoir. We do know that intermediate host seems to be the civet cat. And again, it likely arose in one of these wet markets in China. So if we want to stop these outbreaks from happening, we have to shut down this trade in animal wildlife. We have to say to the Chinese, this has to stop. It has been temporarily suspended by the Chinese. It was temporarily suspended after the SARS-CoV-1 outbreak, but then they brought it back in. So we need to do whatever we can to pressure the Chinese to stop doing this because this happens with regularity. Okay? And again, it's that combination of high population density, close contact with all of these varied animals, with bats being kind of a key reservoir. In fact, some people have proposed that this happens with such regularity that we should already start mapping all the bat viruses that we're worried about, get them all ready to go for a vaccine so that the next time this happens, we can literally go to the shelf and speed up the development of vaccines. That's been proposed. That's going to be very, very expensive. And the problem, having practiced public health for 20 years, right now everybody cares a lot about public health, right? And we've got some public health people here too. We call this the paradox of public health. Everyone is willing to spend a lot of money on public health when our public health system has failed. And then when everything settles down again, money gets cut. So we just go from these pendulums. So hopefully, one thing I'm hoping we see after this epidemic is some sustained interest, sustained investment, so that we can, instead of reacting to these episodically, that we're ahead of it. Okay. So, how serious is COVID-19, the disease caused by this virus? This is, again, I love data, so I'm a very strange person because nothing made me more excited than to spend hours and hours researching data and preparing this presentation because that just, I just love the learning aspect of it. So this was from a very large series, about 55,000 cases in China. The Chinese prepared a report for the World Health Organization summarizing the symptoms. I'm not going to go through them all, but you'll see that in particular a fever and a pretty high fever. So based on another study, over half of the patients had fevers over 100 Fahrenheit. So a high fever seems to be the most common symptom associated with this virus, although, as you'll see, none of these are 100%, and a dry or non-productive cough being the second most. So those have been identified as two key symptoms that patients present with. You can see there's a whole other list of many other symptoms that are less frequently present, and of course, when you look at this, you say, well, okay, that could be COVID-19, that could be influenza, that could be a common cold, that could be a whole bunch of things. So the symptoms are very nonspecific, and that's a problem. Most people, it's a problem because there's nothing that's going to, there's no light that's going to shine saying this is COVID-19, watch out, stay away. It's nonspecific. Secondly, most people aren't particularly ill with it. Okay, and that's obviously good, but it's bad when you compare it to other outbreaks of those other two coronaviruses that I mentioned. You were so sick that you had to go to a hospital whether you wanted to or not. And that actually, in a way, limited the transmission of disease. So a lot of people can be pretty mildly ill with this. I want to be clear that this next data is among hospitalized patients with pneumonia. So a lot of people we don't do lab studies on them. They don't even come to a hospital. But those that did come to a hospital with pneumonia had these types of abnormalities on testing, abnormalities of their white count, elevated liver enzymes, and in more severe cases, they can get pneumonia that we can see on a CAT scan of the chest. The key test that is specific for this virus has a very fancy name. real-time polymerase, reverse transcriptase polymerase chain reaction. The key thing for you to understand as non-health professionals in the group is that this is a test that's looking for the presence of the virus itself. It is looking for the genetic material of the virus, okay? So it tells us whether the virus is there or not. The recommendation from the CDC is that they stick a swab up your nose, further than you thought the swab could go, and take a swab in the back of the throat, both, it's two, so it's two specimens. And if someone is producing, not having a dry cough, but having a productive cough, and they can cough up some sputum, send that as well. Refrigerated, if it's less than 72 hours. If it's longer than 72 hours, it has to be frozen. And next slide, please. I'm sorry, previous slide. I got ahead of myself here. In West Virginia, it began to be done at the state level. So right now, there's only one lab that's doing this, and that is the state lab in Charleston. They started on March 7th to do the test, to perform the test. Prior to that, the test had to go to the CDC in Atlanta. Okay. Next slide. As of March 11th, 8 people had been tested in West Virginia, of whom 7 were negative, and 1 result was pending with the CDC. So, my question for you is, what do you think about those numbers? They're probably low. Well, what's the population of our state? 1.78 million? Okay. So when people say, well, the disease isn't in West Virginia, that is, strictly speaking, not true. I would answer that by saying, well, we've tested 8 people. 7 of them we know are negative, and that's all good. But honestly, it's already here. It's already circulating in our population. We just haven't done enough extensive testing to identify that. And that was certainly the experience of Washington State. Once they were testing, there was actually a flu study going on, and someone had already collected all of these specimens that I had described for you, and wanted to now, it was for a flu study, but wanted to now test them for the coronavirus. There was all kinds of delays, but when she was able to finally test, found people that it had already been circulating long before it was recognized. So I think it's naive of us to assume that this disease is not circulating here. It's already circulating here, okay? We do not have rapid tests, so again, this is going to involve going to a healthcare provider. They would collect the specimens. It's not being done in labs other than the state lab in Charleston. It would have to be sent there. The test takes a few hours to run. The results need to get sent back. So you're looking at about 24 hours if everything goes well. There are rapid forms of this test for similar viral pathogens. We don't have that yet. We also don't have what are called serological or antibody-based tests. So some infections like hepatitis, we actually look at whether you've mounted an antibody response. And that's very useful information. It tells us, have you got immunity? When were you infected? How long ago were you infected, et cetera? So that's very helpful to study what the disease is doing in the population. We don't have either of those tests available to us here now. The Chinese have developed some of them, so hopefully we'll get them soon, but we don't have them right now. Again, when you think about testing, why would we test people for this? Let's make this a little interactive. What would be the reasons for testing somebody?
See if they're a carrier.
Yeah, but see if they're a carrier driven by... So I guess it's almost a guess what I'm thinking question, right?
We haven't tested people that aren't showing symptoms. We're ruling out something else.
You could be ruling out something else, but I guess what I'm getting at is you might want to test them for, because you want to know that they have this disease to guide treatment and et cetera. As we'll see, there isn't any treatment. Another reason you might want to test them is, I think what you were getting at with the carrier, is to understand how is this behaving in the population, and then to start tracing contacts and trying. So there's a population level reason to test, and then there's an individual reason to test, okay? So right now, the reason to test is driven mostly by the population consideration, okay? To decide, okay, who did you come into contact with? You've tested positive now, okay, I've got to find out who you came into contact with to limit the spread of the disease, okay? And unfortunately, next slide, please, we have to acknowledge that we really dropped the ball on testing in this country. So we had delays in implementing testing. And just to give you some sense of how far behind we are, the United States with a population of 331 million, the CDC said today that they estimate they've tested 11,000, little over 11,000 specimens, not individuals. Remember, the CDC recommends 2 specimens per person. The CDC doesn't know about some of the commercial tests, and it's unclear to me from the data whether the state labs were reporting into CDC, but okay, so you have to take that 11,000 number with a grain of salt. Compare us to South Korea, population 51 million people, has tested over 210,000 individuals, not specimens, and are testing at a rate of nearly 20,000 a day. United Kingdom's population 67 million has tested almost 30,000 to date and is testing more than 1,000 per day. Okay? So we have been flying in the dark, and our own state data confirms that we have tested so few people compared to our population. So we don't know, and when we don't know, you cannot control what's going on in the population without knowing who's infected. Next slide, please. So another concept to keep clear in your mind is there is contagiousness, which I'll talk about in a moment, how easily the disease is spread. And then there's the severity of the disease, which in this area we use the term virulence. So for infectious diseases, if you want to tell me how serious an infection is this, the word that we use is virulence. So among cases with the infection, how many die? Probably the most virulent infectious disease that I know of is rabies. You get symptomatic rabies. With a few exceptions, you will die of rabies. Okay, 100% virulence. So we've had a wide range of estimates of case fatality rates for this infection, and I've just thrown up some of them for you here. Less than 0.7% in South Korea, 3.4% globally was an estimate given by the WHO, the World Health Organization, March 5th, 5% Italy, March 9th, Iran, 10%, and I did a calculation for Washington State, March 7th, 14%. Now, why should you be a little bit skeptical about those numbers? Exactly. So the testing has created a major problem with interpreting that. I think those numbers are artifactual. Obviously, if you test a lot of people and diagnose, as you were saying, some of these less severe cases, the denominator is going to go down and your mortality is going to seem to be lower. Okay? On the other hand, you could also argue that if people are dying of COVID-19 but it isn't recognized and it's attributed to something else, that might falsely lower the mortality rate because that's in the numerator. So this number has to be met with some skepticism, and again, it's because we aren't doing the extensive testing that we should be. So in populations where you don't identify all the diagnosed cases, your mortality rate might falsely appear to be higher than it really is. Everybody with me? Okay. And that's mortality data overall. As you've probably heard, that the mortality varies according to certain factors. And this is a study, and I want to be clear, the graphical data that I'm portraying for you is among hospitalized patients with COVID-19. So they're all inpatient. So by definition, these are more serious cases. And it's hard to portray it, but in red are the deaths. In green are the individuals who were discharged. And you can see that when you get to above 50, you begin to see a progressive increase in the proportion of admitted patients dying, so by the time we get into 66 plus, a majority of admitted patients with this infection are dying of this. So increased age is a powerful predictor of mortality for this. At the other end of the spectrum, we also see something unusual, which is that the very young, conversely, are not dying as we would expect. So normally with an infectious disease, it gets the very young and the very old, the extremes of age. That's not what we see here. And it is consistent with what we've seen with other SARS-CoV infections, that it seems to just affect the elderly, not the very young. Other what we call comorbid medical conditions increase the risk of mortality. So smoking, this can be reason number 457 to stop smoking. chronic obstructive lung disease, coronary heart disease, diabetes, and hypertension. Patients that carried those diagnoses had increased mortality. At the other end of the spectrum, there are case reports of individuals with asymptomatic infections, so they test positive on that PCR test that I mentioned to you earlier, but seem to have no symptoms whatsoever. That's been described in a child, that's been described in an adult, and reliable sources of information like the NBA tell me that that NBA player who tested positive was getting ready to play, didn't feel ill at the time that he tested positive. So it seems as if you may have an asymptomatic infection. We don't know how common that is, but that's of huge implications for disease control, because in the field setting, we're trying to decide who has infection based on symptoms. These are the people, and I think we had this before, this discussion, maybe these are carriers, can potentially spread the infection and show no outward signs of it. How does it spread? First, at the individual level. This is an admittedly gross slide, but I like it. It's the one I've used for years to understand how these diseases can spread. So you can probably see that this woman is sneezing, and it's an impressive sneeze. She must have practiced for this sneeze, I don't know. But if you look carefully, you can actually see kind of two cones, can't you? A little higher up, there's a finer mist, right? And then a little lower down, a lot of overlap, there's big, what we medical doctors call crud. Okay, that's the technical term, crud. Right? So that lower cone is much larger particles. And that's why I like this slide, because when this happens, there's actually two ways that the infection can be spread. What happens to that fine mist is that it dries very rapidly and can become very, very small particles, and we'll see that in a minute. And then you have the larger particles, which obviously are going to fall out of the ground, onto the ground very quickly. They're not going to remain suspended in air very much. But they do represent a risk if you're close to this person when they sneeze. This is also produced when the person coughs or even just talks. These droplets are produced in varying amounts. So the most important way that this infection seems to be spread is through those large respiratory droplets, the big crud, okay? And of course, that is a risk through direct person-to-person transmission. If I sneeze and you're close enough to me and that crud gets on you, we can transmit the virus. The virus has no legs, okay? So it is entirely dependent on getting into the mucosa, the surfaces of your eyes, your nose, or your mouth. If it gets there, it can get to your lungs, and it only goes to the lungs. Okay. So, but if you think about it, there's another way as well. I can cough into my hand, onto my cell phone, and then ask Linda to hold the cell phone. She actually was. You put your hand out. Don't hold my cell phone up. Okay. This is what we would call a fomite. So it's an inanimate object. It's not a reservoir. The virus can't stay here forever, but it appears for hours, maybe even a few days. Viable virus can stay on that. Then Linda would touch my cell phone, and then she'd go like that, and then the virus gains entrance. We call this a fomite. It's an inanimate object that can serve as a transmission source for the virus as well. And again, the WHO, I tried to get information on exactly how long it can survive on a fomite. The best I could get from World Health Organization was a few hours to days. Okay. Next slide, please. So some good news is that finer mist and those smaller particles do not appear, as we know it now, to be an important source of transmission for this virus, okay? Which is unlike measles, unlike influenza, unlike tuberculosis. What happens with those is the fine mist floats around in the air for a long time, and there can be airborne transmission both over greater distances and over longer periods of time. That does not appear to be the case right now, at least for this virus, because as you can appreciate, that is a very hard exposure to control, those really small respirable particles. Now, everybody gets confused on respirators. And we have somebody from NIOSH, but they're not from the Respiratory Health Division, thank goodness, right? So they're from Division of Safety Research. So no one is here to correct me, but A lot of confusion in terms of what kind of respirators there are, what kind of respirator, how I should use them, so let's talk about that. The first thing to understand, and this is a great CDC to help you understand the difference between, you've probably heard N95 a lot, is that right? Lots of N95, okay. So to the left is a surgical mask. People sometimes call that an N95. It's not an N95. It's a surgical mask. And I tell the medical students, so where did this surgical mask come from? And then they overthink the question. I say, surgery. And who wears the surgical mask? The surgeon. And why does the surgeon wear the surgical mask? Doing surgery. Okay, there's the concrete thinker for us here, yeah. But why does the surgeon doing surgery wear the surgical mask? Because the patient is open, thank you. And we don't want him to go onto the open abdomen, okay? So the point of all that is, if you remember all that, then you understand how a surgical mask should be used. It protects us from the wearer. So the surgical masks should be used from a population level. If people are coughing and ill, we want them to be wearing one of these surgical masks, okay? The next level of protection up is an N95 respirator. Next slide, please. So that's shown in the bottom left for you here. That is a bit of a tighter, there's a disposable kind here, that's a tighter fitting mask. And that is something that we do, and my clinic does this because we're an occupational medicine clinic, we do fit testing. So workers that are known to be working with respiratory hazards in the workplace, we bring them in and we actually measure and fit a respirator just for them. It's individually done. It has to be done every 12 months. It's a big deal, okay? Why would I have concerns about you, sir, wearing a respirator? Exactly. And I admire his beard because I could just never grow one like that, okay? So anybody wearing a respirator cannot wear any type of fitted mask, okay, because they just can't get the appropriate seal. When they went to fit test me, because I went through it as a learning experience, I'm a very difficult person to fit test because I've got this kind of long, narrow face with a skinny nose, and if you look, my nose actually deviates off to the right a little bit, okay? I can tell it because I can see it out of this eye, but not that eye. And they had a real job fit testing me. So the point is, fit testing respirators is very, very challenging, time-consuming. It's a big deal, okay? But that's what you'd have to use to get a good fit for the bottom left respirator, and the top right respirator is the next level of protection. Same idea, you would also call this an N95 fitted respirator. This one has cartridges that you can change for if you're having certain exposures, gases, etc. You can use specific cartridges. That also has to be fit tested. The BMW or Cadillac of respirators is what you see to the bottom right. That would be a hooded respirator. So you, sir, could wear a hooded respirator. It doesn't matter. You don't need to be fit tested. You don't. You could have as luxuriant a beard as you wish, because it's a hood and there is supplied air. So unlike the others where you've got to draw the air through, this type provides it, pushes the air in, and everybody loves those. They're very, very expensive, okay? So what's important is if you want to get really good protection from those small, if it was transmitted through those small respirable particles, you need higher levels of protection than the surgical mask which President Xi Jinping of China is wearing here. So even he, when he was visiting Wuhan a few days ago, followed Chinese regulations that those surgical masks are all that you get. The higher, more protective masks are reserved for healthcare workers, and he followed that rule himself, which is interesting. Okay, next slide. So the current recommendation for healthcare workers is that they wear ideally a respirator, but there is a shortage right now. Every hospital has just enough respirators to see them through the next few days. So there's a major concern about shortages of N95s. I think if you went onto Amazon now, you probably could not buy an N95 respirator. The national stockpile is about 17 million, which would last us one day in the event of a serious epidemic. Okay? So they should be used by healthcare workers. If they're unavailable, then at least wear a face mask is the current recommendation. You can see that this individual has a full face shield, if not goggles, gloves, and a gown. Okay? There really is no role, and we discourage the use of people walking around with surgical masks, as you commonly are seeing all over the news right now. There's a couple of problems with that. Anyone want to guess what the problems are?
They wear them under their nose.
They wear them improperly, yeah. So they wear them under their nose. They reuse them, and they don't take appropriate hand hygiene, so they've contaminated their own respirator as they don and doff it. There's another kind of public health problem with it, too. Yeah, okay, you don't know whether they're sick or well, but another factor is if there's such a shortage, then the people that really needs them can't get them, and that's what we're seeing now. You can't get an N95 respirator, and you can't get toilet paper, and you can't get, well, all these things are getting hoarded. So, three goes around. 3 goes around. Shave the beard. 3 goes around the toilet paper. Yeah, okay. Yeah. That's a good one. All right. Gloves and gowns as well for healthcare professionals interacting with known or suspected cases of this infection. And you can see an individual here checking cruise ship people in California recently. Next slide, please. Another thing is I mentioned you want these on the patients as soon as possible. So a lot of hospitals are moving things outside, having a triage center outside. There's somebody there with the appropriate protection on to conserve the protection. And then if you come in and you're suspected to be a COVID-19 case, a mask is put on you before you go any further. And obviously an outdoor setting provides inherent protections. There's nice breezes flowing, etc. So you might see more of that moving forward. Okay. Next slide. Additional measures, I'm not going to go into too much detail. You've probably read a lot about this. Appropriate hand hygiene. Make sure you're washing for at least 20 seconds. Alcohol at least 60%, cleaning surfaces with appropriate agents. And then there's a concept that we call social distancing, which is maintaining a distance of 6 feet or more from other people. Again, with those respiratory droplets, they'll fall out of the air. You don't want to be close enough where someone can directly get those on you. Okay? And there's a link here for more detailed guidance. So CDC has tons of great resources, and you can see much more there that I won't go into details on. Next slide. So how can we stop the spread at the population level? Hopefully you don't get too lost in the deep academia here, but the way that we measure infectiousness, or what people commonly call contagiousness, is a number, and we're not very consistent in epidemiology and terminology, but we call it the basic reproductive or reproduction number. Okay? That is, when this virus is spreading, or bacteria, or any infection is spreading through a population, how many people are getting it from one particular case of the infection. Okay? I provided a more verbose definition here. The basic reproductive number is going to be influenced by the number of contacts per unit of time. So moving forward, and you probably know where this is headed, we're going to be all at home telecommuting with annoying kids that aren't at school. Okay? And so mass gatherings are probably going to stop, etc. That's to reduce that number, reduce the number of contacts that each of us have. That's the whole point of those. That's why these sporting events, big gatherings have all been canceled, etc. throughout the country. The probability of transmission with contact, that's a relatively fixed, related to, what's the probability of me sneezing and you getting it? And then how long, if I'm a case of the infection, how long am I able to spread the disease? How long am I infectious? So those are the 3 variables, some of which we can control and some we can't. So this is shown for you in another way. When the basic reproductive number is greater than 1, the disease is getting worse because each person is spreading it to more than themselves, right? So in epidemics, the higher this number is, the worse things are in terms of how it's spreading through the population. If you have a value of 1, it's a steady state situation. And importantly, to control an epidemic, our goal is not to stop transmission, but to sustain a basic reproductive number of less than 1. If we can keep it less than 1 for a long enough period of time, we'll eventually get rid of it. Okay? And we know this from eradicating diseases. We've eradicated smallpox. We learned a lot from that this strategy works. You don't have to stop all transmission. You have to keep it below that magic number of 1. I've shown for you here some typical basic reproductive numbers for common infections. You can see measles tops the list. You've probably heard that measles is one of the most infectious diseases that's out there. It is spread by those tiny respirable particles, and that's why with, in some cases, declining vaccination rates, sometimes people opposed to vaccines are not getting vaccinated or getting under-vaccinated. The outbreak that we typically see is measles precisely because it's so infectious. It's kind of the canary in the coal mine, so to speak, of infectious diseases. And you can see a whole bunch of other numbers there, and a study that I found indicated that the basic reproductive number for SARS-CoV-2 is estimated currently to be somewhere between 1.5 to 3.5. Now, I don't want you to think this is a fixed number. It's not. It's a very dynamic number. These numbers are what could be the situation if we don't intervene. Again, we hope that this number is going to change for this virus. As we apply these measures, we hope to keep it below 1 and get ahead of this. Okay? Next slide. So a little bit more here, some other terminology. You've probably heard that magic number of 14 days, right? People were quarantined for 14 days. Where does that come from? Well, we know that for most infections, you're exposed, and so the top diagram, that first downward arrow that you see is when someone becomes infected with a virus. Then there follows a period of time called the incubation period on the lower line, which is defined as the time that you got infected, so when you breathed in the virus, to when you started to develop the symptoms of that disease. That's called the incubation period. Then you enter a symptomatic period, and then you can see the outcomes. The person dies, recovers, develops immunity, becomes a carrier, etc. At the top, you see the dynamics of infectiousness, how that relates to the spread of the disease. Again, a person is infected. Then there follows something called the latent period before they can spread the disease. Now we enter in the infectious period. And then you can see they become non-infectious, they're removed, etc., from the population. So an interesting thing is the lines don't fully line up, do they, right? If you look carefully, you'll see that in this diagram, as depicted, the infectious period precedes the symptomatic period in that figure, okay? That's of huge consequences, and that turns out to be true for most infectious diseases. So most infectious diseases, you can transmit it before you yourself come down with symptoms. The good news, so, probably some of you had kids who had chickenpox, right? And you saw your kid and they broke out in chickenpox, and you say, well, I'm keeping you home from school. The horse had already left the barn at that point, okay? Your kid was spreading chickenpox around for several days prior to the eruption, and that's what I'm talking about here. The good news is for SARS-CoV-2, it does not appear that you are infectious prior to developing symptoms. Again, there's a lot of uncertainty. That's a tentative statement. But right now, again, based on the experience with SARS-CoV, the earlier virus, we aren't seeing a lot of spread before you become symptomatic, which is good. Nevertheless, people are behaving as if they could spread the disease, and that's what you should do, but at least there isn't a lot of evidence that it's spreading at that earlier point. The incubation period for SARS-CoV-2 is estimated to be about 5.1 days. The CDC is saying we're going to assume a range of 2 to 14 days, but that's based on the Middle East Respiratory Syndrome. There's an asterisk at the website, okay? So that's what's true for a related virus. We assume it to be true, and it seems to be true for this one, but we don't know with certainty. Note, about 1% of cases go on for more than 14 days, and there's also some troubling data that people are still shedding the virus even after they recover symptomatically from the disease, which has implications for the spread. All right. So this is a slide to kind of put it all together. The New York Times had a wonderful article, and they show to the left the mortality rate on that axis as a logarithmic scale. So as you go higher up in this graph, the infections are more deadly. And then from left to right, contagiousness as measured by that basic reproductive number that I mentioned. So as you go more to the right, the disease spreads more quickly. The SARS-CoV-2 virus is shown in that range of pink. Again, we don't have really good data to pinpoint this down, but it seems to be have a higher mortality than, say, influenza, and also be more contagious than influenza. At least that's the kind of range that it's in right there, okay? And again, those numbers may change over time as we get more data. The mortality, as I said, is, you've seen some of those estimates 0.65% South Korea, all the way to 14% for Washington. So how can we reduce the spread, again, at that population level? I told you I was going to quote Scripture. Here is the Scripture, Genesis 8:6, and it came to pass at the end of 40 days that Noah opened the window of the ark, which he had made, Exodus 24:18, and Moses went into the midst of the cloud and got him into the mount, and Moses was in the mount 40 days and 40 nights. In Mark, Jesus was tempted by Satan for 40 days. That number recurs over and over again in the Old and New Testament. It's also in the Quran. So, next slide. The Italians in the Middle Ages had a problem. This is long before we knew anything about germs or disease transmission, but here was the problem. The city-states of Genoa and Venice were the New York cities of the time. They were huge commercial empires. Lots of trade. And they noticed that when a ship came in from Asia, not long afterwards, a disease spread throughout their city. It happened with regularity. So even though they had no idea about disease transmission, the circumstantial evidence was compelling. And so they said to these ships, and anybody know what that disease was?
Wasn't it the Black Death?
The Black Death, yes, or the plague, right. So it was actually on fleas that were on the rats on these ships. And so they knew they had a problem, and so they developed the first time that we prevented the activity of people to control the spread of an infectious disease. They had these ships stay offshore for how long? 40 giorno. 40 days, again, based on Scripture, hence the English term quarantine. Okay? So that comes from that. Now, isn't that when you go to a cocktail party? Please use that. Isn't that a good cocktail party conversation to say, now let's look at corn. Key point for our purposes is that quarantine is a restriction in activities of seemingly healthy people because we're concerned they were exposed. Okay? That's a quarantine. Okay? And quarantine was used a lot in Toronto during the SARS-CoV outbreak, the CoV-1 outbreak that we'll talk about. And again, when you go back to that figure I showed you earlier, you now understand why we would quarantine for 14 days, because that is the incubation period. If you're going to get sick, we assume that it's going to be within that period of time, okay, of healthy people. Okay? Next slide. However, quarantine requires quick and accurate identification through testing. We've talked about how that's been a problem so far. And that has really gotten us behind the 8 ball in responding to this. It requires compliance. In the Toronto quarantine, about 57% of people actually complied with quarantine. If you remember Ebola, there was a journalist who was covering Ebola. She came back and then was seen at a restaurant getting soup because it had really good soup. Her defense was, I went through the drive-through lane. Still, people weren't too receptive. She was supposed to be at home. So people don't necessarily comply with quarantine. And that the infection is transmissible during that incubation period. And as I said, right now, we don't have evidence that that's the case, at least for this virus. Isolation is different. Isolation is the restriction of activities because you are sick with the infection. So we will isolate people for the infectious period has passed. And these are the current recommendations from CDC. If you are mildly ill, you should stay at home. You should not go to a hospital or an urgent care. You risk spreading it to others. Daily checks to make sure you're fine. Most of the patients who are mildly ill should stay at home. And that would be self-isolation. If you require hospitalization, the recommendation is a single-person room with the door closed, and that we've got a very small number of airborne infection isolation rooms. The reason we have a very small number of those is they are negatively pressurized and have a separate ventilation system with respect to the rest of the hospital. So air is always going to go leak, but in this case it can only leak into the room, it can never leak out. And all the healthcare personnel have to gown up and respirator up to go in and out. We don't have many of those beds, so we want to spare them only for patients that are undergoing aerosol-generating procedures, things like suctioning, CPAP would constitute that, nebulizing, etc. If that's going to happen and it's a COVID-19, that's the room they'd be in. But we don't have many of those rooms. Next slide, please. So, a lot of people ask me, is our response overblown? Okay? I don't know about you, but I have never seen anything like this in my lifetime. I have never seen anything like this. Okay, I'm not seeing anybody saying, yes, I saw this. It's anything worse. Okay, so I've never seen a global response to an infection like this. And the question I get all the time is, and then people compare to flu. I say, well, given that we have, the flu numbers are worse, why do we never do that for the flu? And we're doing that for this. I get asked that question a lot. And this is a slide, and actually the New York Times picked up on it a few days ago and ran a similar version, and it's all a lot of people's social media feeds too. But it's a very elegant slide that explains what we're trying to do now. We have moved really from containment to, which would mean not letting this get a foothold in the United States. Again, that boat has sailed. We can't contain anymore. So what we're really trying to do is mitigate. And what you see here is a solid purple graph of the number of cases that we could have without intervention. You can see both that there are more cases, but that they're happening over a much more rapid period of time. And then you see a flattened curve where, we don't stop it entirely, but we reduce the number of cases and we spread them out over a longer period of time. What this is intended to do is, if we can at least slow this down and mitigate it somewhat, the very ill that I mentioned, those who are older with comorbid medical conditions, we're going to have a lot of people hospitalized. In the most extreme cases, we're going to have people on ventilated beds. We have about 75,000 of those beds in this country. That's it. And we can't suddenly come up with more ventilated beds like that. So we have these fixed resources, and in disaster preparedness, this is what they call the surge. So what we're trying to do is limit the surge, spread things out, so that if we can't stop it in its tracks, let's try and have a situation where we can have enough ventilated beds for everybody, enough hospital beds for everybody. And the reason I went from, this seems to be excessive to seriously concerned was the experience in Italy. This is what we're seeing in Italy right now. The physicians in northern Italy are having to decide who gets a ventilated bed. And in other words, what they're doing is they're saying, if you are so sick that we don't think you're going to live, we're not going to bother to give you a ventilated bed, because it's just going to take a ventilated bed away from someone who might survive it. And you can imagine how horrible those decisions are. And we don't want that kind of a situation. So that's why we're seeing such unprecedented measures. And remember, this is on top of the seasonal influenza. It's additive. So it's not like, human beings tend to worry about one thing at a time. So it's easy to forget that we're still having influenza and we're still having all the usual things that a hospital deals with. This is on top of that. Okay? Next slide, please. So when will we have a treatment vaccine as the final point? Next slide. So to summarize, right now, treatment is symptomatic or supportive. We don't have any specific treatment for this virus. You can take medications to lower your fever. The ultimate supportive treatment would be to put you on respiratory support, intubate you, ECMO, those types of things, to see you through if your lungs aren't working. But it's nothing specific for this viral infection. Beware social media. There's lots of, I heard this works, I heard that works. Some of them are quite frankly bizarre, like drinking bleach is, making the rounds. Do not drink bleach. But there's, on the less extreme view, chloroquine, a lot of anecdotal reports. The short answer is we don't have any evidence-based treatment for this viral infection specifically. We do have antivirals for other viruses, and there are clinical trials underway right now in China, actually, for the combination of lopinavir and ritonavir. Those are used to treat HIV. Remdesivir is a new antiviral that's used, that came out for Ebola. That's in a clinical trial right now. Interferon alpha, corticosteroids, those are all under study right now. So we're trying to learn if they work, but we do not yet know if they work. And there are no antivirals available for for the Middle East respiratory syndrome that I mentioned. There's currently no antivirals for that. So right now, nothing that's going to be forthcoming in terms of specific treatment anytime soon. Next slide. In terms of a vaccine, unprecedented. Normally we test in animals. We skipped that altogether and went straight to a human study. remember that the drugs that you take and the vaccines that you've given take years and years and years to develop and test. This actually takes decades in many cases. And it starts with what we call a phase 1 study, and a lot of them used to happen. If you remember Kendall was always advertising in Morgantown. Nobody remembers Kendall. Yeah, she remembers Kendall. You worked there. Oh, we have people who worked at Kendall, okay? So we had a pharmaceutical company and a lot of healthy young people who were, would go for the weekend and be paid a lot of money to test these drugs, right? Why would we test it on healthy young people without disease? Because in a phase 1 study, what you care about is safety. So these clinical trials work in a 2-step manner. First, we have to show that it's safe. That's why we do it in healthy young people. Not that it works, just that it's safe. What's that? First, do no harm, right. And then once you've shown that it's safe, then the second step is to see if it works or not, efficacy. Okay? So to give you some idea of the timeline here, a phase 1 trial right now for a vaccine for this infection is recruiting 45 healthy adults in Seattle. You can go if you're interested in participating in this vaccine and going to, maybe Seattle's not such a good place to be right now, but you can participate in this study, and it's a 14-month study. Right? That's going to be a year plus just to show that it's safe before, assuming it's safe, we can then go to phase 2 studies to begin to explore if it works. Those could be about a year. And then once we've shown it works, then we've got to mass produce it and get it out. So I know there's been a lot of talk about vaccines. Quite frankly, I think this will be over by the time the vaccine becomes available, given the timeline that I see. And then, unfortunately, once it's over, the paradox of public health says nobody cares anymore, there's no more money, and we'll lose interest in a vaccine until this happens again. Sadly, that's the pattern that we see. And there's no vaccine for SARS-CoV-1. Again, that doesn't necessarily mean we can't make one, but it may reflect a lack of interest because it's a small infection that affects people in Saudi Arabia rarely. Final slide. So to conclude on a positive note, our daughter is in northern Italy right now. She's in lockdown. She's a teacher. She just got married this past summer, had the fairy tale wedding, living in Europe for 3 years with her new husband. She was, sending us pictures of Venice, and we went here, we went there, and everything, and now this happens. So Italy right now, you can go to a grocery store or a pharmacy, and that's it. Otherwise, you're at home. But she sent us this picture. The children are drawing rainbows, and they've written in Italian, tutto andrà bene. In English, everything will be all right. So, to conclude on a positive note, we've got a lot of knowledge, we've got a lot of good people working on this. We'll work together, and I'm confident that everything will be better in spite of this. Thank you very much, and I'll entertain any questions that you might have. Oh, you have to come to the mic?
Cough on it. Okay. Do we have any Purell? Actually, my wife worked with these people at Kendall, and it was incredible, but it, just as you emphasize, it takes forever. You want to have efficacy. You also want to mitigate any side effects, and so it's very important to get it right the first time, not the 5th time, and find out that side effects and some of the other side effects are worse than having coronavirus. I'm by trade, actually. I worked for the VA for 41 years in Conning, and I'm one of my roles is as an epidemiologist. So I have a public health degree taught by somebody like your expert. So I'm not the expert MD. I'm the master public health expert. And we do that a lot for the workers' comp program. What I guess I'm trying to do with the VA, and I just got off a call, I'm the president-elect for the West Virginia American College of Healthcare Executives chapter, and we had a huge conference scheduled for a month from tomorrow, which we agonized over, because the American College of Healthcare Executives in a week and a half has their Congress of about 9,000 people for all of North America. And this weekend we made a hard decision, first time in 52 years. Even Katrina didn't stop it back then, but we've canceled it for 9,000 people in Chicago because we don't want to be irresponsible. I guess where we're all coming from, and the argument was we're only going to have 100 people down there, and I said that's probably 99 people too many. So we've decided we're going to postpone it till the summer if things get better, and we agree that things will get better. But that's, I guess, my biggest concern with speaking to the VA about this nationally is how do you, because I had a bad experience with H1N1. We have a training academy in Baltimore. There were 122 people. I know there were 122 people because I had to fill out workers' comp forms for 122 people. A guy came in on Monday, coughed all over them, then left and came back Thursday morning and says, guess what, I got H1N1. And everybody ran out of the building, seriously. And they ended up going to the local emergency rooms and, and I had to go down and talk to them. I told them, you're probably going to make it. And the only person we had was concerned, it was a 6-month pregnant woman. She didn't get exposed, actually, or convert. But I guess what I was trying to tell these people, we only had 2 people that missed any work after that and were mildly sick with H1N1. But they all said, we're all going to die. And they didn't. So what I guess I had to try to do is keep calm heads, but also, as our president's been criticized badly, is some people say he's overreacted, sometimes people say he's underreacted, and instead when he asked for $2 billion, they gave him 8 because they said, you're not really taking this seriously. What should you be telling us to worry about? Because my wife wouldn't come tonight. She's a healthcare worker, and my daughter called me and told me not to come tonight. She's an anesthesiologist, and I said, well, good luck. I've lived a nice long life. But anyhow, and I'm not really worried about it because I will wash my hands after I touch this microphone. But seriously.
After you touch this fomite.
This fomite. Well, I didn't know that term, so I learned something for this tonight. But seriously, you don't want to get a panic. The sky's falling, and this thing with Black Plague destroyed Justinius when he redid Rome from the Byzantine Empire and destroyed, and then for 500 years we had the Dark Ages after that. So I don't want to get people lulled into complacency. My retirement's gone, so it'd probably be good if I didn't make it because my retirement's been eaten up a lot, but it will rebound. So what should we tell people? Sorry for that long question.
Yeah, no, so I didn't anticipate Emperor Justinian questions, but so I think you have to keep clear these concepts, which I tried to emphasize, of the infectivity versus virulence. So, based on the mortality data, most people are going to have a mild illness. So that's true. And you're right, President Trump was criticized when he made the mortality statement. I think the numbers are going to go down. And he said it was his gut. And unfortunately, I agree with him, and he was right. He just didn't explain it very well. And as it turns out, Tony Fauci, who's the guru of doing this, you've seen lots of Anthony Fauci. It turns out that he had explained this to the president and then wrote a letter to the New England Journal of Medicine explaining a lower mortality rate. So you have to keep issues of disease severity and how it spreads and contagiousness. So in essence, my main worry is that, so people say, what do you think is going to happen? I think the disease is already circulating. I think a lot of us are going to get the disease. I think I'm going to get it. I anticipate getting it, and I'm going to be mildly ill, knock on wood, for a couple of weeks, and I'm going to be at home. That's a very real scenario moving forward. What I do worry about is the elderly with comorbidities and an overwhelmed healthcare system. And as you know, with disaster preparedness, one of the key things is that what's going to be in your emergency room a small number of cases of disease and then a lot of very terrified people. And we have to work against that and come up with logical approaches like we're seeing in South Korea with drive-through testing, have people outside. The lesson of the SARS epidemic in Toronto in 2003 was that it was bad healthcare. It really was. Bad infection control in the healthcare setting. That was the lesson. Excessive quarantine. So we know what we have to do. And as a Canadian, I have to quote Tony Fauci again because he said yesterday, we need to be like Wayne Gretzky. And I love this because every Canadian knows why Wayne Gretzky was the greatest hockey player ever. Because the great hockey players go to where the puck is. Wayne Gretzky is unique in that he would go to where the puck was going to come. So we need to get ahead of this. We need to anticipate. And it's not that hard. We know what to do. With simple population-level measures, behaving rationally, not panicking, not following these rumors, and doing simple population-level measures, I think we can get ahead of this. But I do see more disease ahead. And I do see more social dislocation. That's not going to get better. That's going to get worse. And then there's a lot of unknowns. As I said at the beginning, there's a lot of unknowns. My wife is here. She can tell you how many times my predictions have been wrong, right? So,
why are you sitting so far away?
Social distancing. Sir, I think did you have a question? We need the mic. Go to the mic. Okay. 6 feet apart.
Healthcare workers. I am a healthcare worker. I work with elderly people. Is face shield, surgical mask?
Yes, if it's
Gown,
available, yeah.
Gloves.
For known or
gloves.
suspected COVID-19 cases, yep.
And then just standard sterilization practices.
Yes, standard precautions plus that for known COVID or suspected COVID. And the CDC has a good link on specific recommendations for healthcare.
How about for the regular environment, like things you wouldn't normally perhaps sanitize, like doorknobs, in and out of a waiting room, that type of thing? Or waiting areas specifically?
I don't think the CDC has anything specific, but you could check the link. I just focused on PPE.
All right, thank you.
Sure. Wow, okay.
Can you repeat again how long the virus is viable on an object, what to use to clean it, and how long that disinfectant cleaner should stay on before you dry it off?
Okay, some more detailed questions. So to answer your first question, I tried to find a specific time frame of how long the virus is viable on surfaces like that. It turns out to be pretty complicated. It depends whether it's a hard surface or a soft surface. It depends on the ambient temperature. The best estimate, which is imprecise, was the WHO saying it can survive for hours to days. In terms of what can kill it, usual practices, the usual disinfecting wipes, you don't need anything special. This doesn't appear to be a particularly hardy virus. So some infections produce spores, and they're resistant to drying and temperature. You may have heard of Clostridium difficile, which is the #1 health. This is not like that. It seems to be pretty sensitive to the usual measures. And quite frankly, I'm not sure I know how long you wait for it to dry off, but you use a typical disinfectant and that'll do the trick. There's nothing special. It's not a particularly hardy virus outside of a host.
So my daughter had a baby 9 weeks ago, and she's going back to work in a healthcare facility next week. So I've offered to go, she lives in Connecticut, to go up and take care of the baby so she doesn't have to send the baby to daycare. But she said, well, it might be more dangerous for me to come up there to take care of the baby because she could be bringing the virus back to me. So which would be the better, being a good grandma and going to take care of my grandchild or staying here and letting her go to daycare?
Wow. Okay. So competing risks. I don't have an easy answer for you. I just had a phone call with a friend who was wrestling with many of the same issues, whether to travel for the birth of a first grandchild. What I can say to you, I'm not going to tell you what to do, but I can give you some of the things to think about. So to remind you, there isn't a lot of evidence that people, before they get sick, are able to spread the disease. That doesn't mean that the limited evidence based on similar viruses, that doesn't seem to be a big one for this virus. But again, you could touch something, it could be brought home, et cetera. That remains a risk. When you think about travel, the key for me is how are you traveling? There would be a big difference between you driving to Connecticut versus trying to take a plane or a megabus. You probably don't look like the megabus type, but it's not travel, it's contact with people that we worry about. So always bear that in mind. How can I manage how can I come into contact with the least number of people and keep the greatest distance away from those people? That's what you've always got to be thinking. Which scenario allows me to limit my contact with other individuals and keep as far away as possible? The medical students were asking me because they've gone to online. As you know, the university's gone to online. They're going to online to limit person-to-person contact. The problem is when you teach medical students, it's not fully online, so they're still doing anatomy. And they're emailing me, can we do anatomy class? We're still having to do anatomy class. Well, if you can keep 6 feet apart and you're good hand hygiene and you're cleaning off those surfaces, those are things that you can do to reduce your risk. I don't have an easy answer, but think about how are the people that me and my grandchild and my daughter, what is reducing the number of contacts that we have? And, so is daycare a greater risk because the child's going to be coming into contact with more? The good news is it seems to be very mild illness in children. And there's also this concern that people have had, which I can address, about super spreaders, this idea that the children are actually spreading it widely around. There's not a lot of evidence for that's the case. Not a lot of evidence that children are infected or that children are spreading it to adults. So I don't have an easy answer, but think about that as you kind of mull through your decision. Did we wipe it off? Yes, we did. Okay.
Yes, I have a question. I'm not sure that you can answer it because I don't know really how to answer it myself. But I have several older congregation members in my churches, and several of them have come up to say, well, if I get this virus, I'm old. Is anybody going to take care of me, or am I going to be shoved to the wayside? Like those needing the water, the air-conditioned beds or the beds with air. This is a real problem for them. They want to know because maybe they're 80 or 81, or I have some in their 90s. If they get this and they're healthy and they drive to church every Sunday, if I get the virus, are they going to care about me? So they're elderly and they want to know. But I don't know how to answer it, and I thought maybe you did. Okay.
Well, you gave me an out, which I always appreciate. I appreciate questions that say you may not be able to answer this. So the experience in northern Italy indicates that that's a very real concern. Yeah, they are struggling to meet capacity, particularly for ventilated beds. As I said, we've got a fixed number of those. That's not something we can easily increase. So that, to me, the reason that we are taking these unprecedented measures at a population level, canceling sports seasons and everything, is precisely because of those people. Those are the ones we worry about. Now I'm going to cough, unfortunately. Sorry, it's just a dry throat. It's just a dry throat. I'm stepping away here. But that's why we're taking those draconian measures. It's precisely because of the elderly and those with comorbid conditions. Again, this is a mild disease in most people, but we've got a fixed healthcare capacity for those people that you're worried about. That's why we have to do these mitigation approaches so that we don't get this sudden surge in seriously ill people that overwhelms our healthcare system. So the concern is legitimate. I don't have any easy answers.
Can you give us some specific recommendations of what can be done within the worship service?
Within the worship service, okay.
Yes, I'm a pastor, so I'm thinking of that. So.
I should have anticipated that question, but did not. You're not going to be doing anything different in the worship setting that you wouldn't be doing in other settings. So again, thank you. Dry throat. You want to keep people as far apart as possible. You want to limit contact. So I don't know how you do your communion in this service, but in some churches there's a communal cup. The communal cup you don't look like communal cup people here. No, The pastor's wife is no. Is there a communal cup? There was. Not anymore. Okay. So those kinds of things, cleaning the surfaces, etc., those kind of usual practices. Are you at a different church?
Yeah, I'm in Fort Ashby.
You're at Fort Ashby, okay. So again, you want to limit the contact between individuals, keep them separate, clean down the surfaces, be aware of those, teach people about good hand hygiene, etc. And then the ultimate decision, which I think is looming, is when do we stop the services? And we're not there yet, but we could be heading there.
Sure. Should we also pass the offering plate? Would it be better to, say, put the plate up front and then let people come and just put it directly?
That would be an excellent idea. Okay. I would agree with that. All measures to stop, so think about it. Unfortunately, it's invisible, but think about all those opportunities where I touch something and you touch something. Okay. I touch something and you touch. You want to limit that as much as possible. And so, a lot of this goes well beyond the medical, but I heard somebody say, look, if you're getting groceries, can you go once every 2 weeks when the grocery store isn't busy? Maybe get, the person to come out. Always be thinking about how can I limit my contact with other people, both how close I am, the number of people I come into contact with, and all those opportunities for, us touching things, door handles, etc.
Okay, thank you.
Sure.
I have like 3 questions for you.
It's the same price.
One, the colleges are closing, but yet the public schools are still in session.
Correct. I think excellent question. I think the reason the colleges did what they did is because, unlike the local schools, we have all these students leaving for spring break, going all over the country, sometimes internationally, and the worry was what would happen when they all came back, which is a little different than the schools, where the children are more localized. But Virginia has stopped extracurricular activities. Ontario, my sister just emailed me, I think Ontario has closed schools for 2 weeks. So I think you'll see Ohio for 3 weeks. Yeah. So I think you're going to see closures of schools soon. Remember I said there's going to be more social dislocation. That's one example that I see coming down the pipe. And those of us who can telecommuting from work.
Okay, and part of this question is, so should we all go home and lock ourselves in and...
Well, again, I would say no at this point. We don't know, but again, one of the reasons we don't know is we haven't tested. But right now, I don't see that as being justified, but that could come very soon. And things are moving incredibly fast, so that could be next week.
Okay, and we have some people in our family that work at the hospital.
Mm-hmm.
Can they catch it and bring it back to the... I don't understand, I'm just trying to figure it out.
Well, again, keep your focus on the modes of transmission. So it's sprayed by it's spread by those droplets that you get directly from someone sneezing on you, or I sneeze on this, I touch that, and then this is infectious for a few hours. So those family members that work in a healthcare setting, if they're pretty good about washing their hands and cleaning things off before they come into the house, that's a reasonable way to reduce the transmission.
Okay, because one of them has a baby.
Right? So that person should be particularly careful about those measures.
Okay, and then my last question for you is, if you have a medical procedure coming up, but it's not absolutely necessary, should you postpone it, or?
Well, I don't think you necessarily need to make that decision, but certainly Clay Marsh said this yesterday on Hoppy Kercheval, that we may see those elective procedures being delayed as this becomes a bigger issue. So if our hospitals are dealing with a lot of COVID-19 cases, you may see your hospital saying that we're delaying your elective surgery right now. But you may have been worried about somehow that increasing your susceptibility to infection. I have not seen that. So I think the hospitals are very well aware of the protections they should take, which, by the way, are not unique to this virus, right? Washing hands in the healthcare setting should always be done, okay? So there's nothing about the disease control measures that are any different than good, usual hospital practice. So if you have an elective procedure, I would not delay it because you're worried about this infection, as things are now.
Thank you.
Ever since AIDS, universal precautions are universal.
Right. And I'm old enough to remember the surgeon going in without gloves on. It's unimaginable now, but my medical training started before the HIV epidemic. Yes, sir.
You mentioned that there could be a day coming when churches need to consider moving away from services. Can you tell us kind of, like I have clergy friends all over the country, and some of them are canceling services for this weekend, and some of them are not. And I don't have any idea how to think about that as we lead large groups of people that are oftentimes elderly. So what do we need to be thinking about as we're making those decisions to continue services or not continue services, or what are the things we need to be putting in place?
Those are very tough questions, and people all over the country are asking those same questions. I think you need to rely on the public health experts to guide you, and some guidance is coming out.
I'm asking you.
Oh,
so,
yeah, okay.
Hence, here we are.
Right, okay,
yeah.
Fair enough. But what I think is going to happen is there is going to be guidance provided by, if you're in Mon County, Lee Smith is going to say, okay, the time. You're going to get those recommendations from those sources.
Do you think the recommendations will be that specific?
Yeah, it won't be, cancel church. It'll be sure. no gatherings, So what some states have done is no gatherings greater than 250 people. And so you're going to begin to see those, and it'll be fairly specific. And so I think that is, if I'm right, then that's a few weeks away, okay, as things are going. But I would expect, at some time in the near future, you're going to be told you should cancel your services. Correct. Marty says it wouldn't hurt to switch to online in an anticipatory way. Again, absent, 8 tests in West Virginia, we do not know what this disease is doing in our state. We just don't know. We just don't have enough information to know that.
I have several questions associated with the testing. Is the testing particularly difficult or involved? Does it require scarce materials?
Yes and no. Normally I would have said no. We do swabs. Again, the way the specimen is collected, the mic's still on, is it? I'm not, I sound, okay. I sound more, the way that you take the oropharyngeal and nasopharyngeal swab is the same as you would for any respiratory pathogens. There's nothing unusual about that. The Chinese sequenced the virus in January, shared that with anybody who wanted it, and that's the basis of the probe that's used to detect the virus. And again, this is all pretty, there's nothing unique about the testing. There were a lot of problems in terms of getting the test set up and distributed. There were invalidated tests. There were additional problems in who could be tested. So there were probably, in retrospect, overly stringent criteria in who the CDC would allow to be tested.
That's my second question. Why was there that, this stringent requirement before you could be tested if one of the tools in epidemiology is to figure out where it's coming from and where it's going?
A fair question. It's not uncommon in infectious disease outbreaks to say, look, because the other extreme is, you're going to MedExpress, I got a sore throat, test me for that new virus, and you're just wasting tests. So it's not uncommon to have criteria because of limited test availability and cost, et cetera. But in this case, in retrospect, especially since, as you said, we were in this catch-22, we had delayed testing so much, and this was in Washington State, where the test was not available, the disease was spreading more rapidly. The person that they wanted to test that initially was declined turned out to have tested positive. So to answer your question further, though, there is concern that some of the reagents associated with the test as this ramps up could come in short supply. So the answer is yes and no. There's nothing unusual about this test compared to tests we do all the time. There is a specific genetic probe that you have to have that has to be shared. And there is some concern, I've been reading some articles, that some of the reagents involved may be coming in short supply as this ramps up.
Because of a manufacturing limitation or because of basic resource, like it takes lithium or something that we don't have?
There were, it's a pretty complicated story. There were delays in FDA approval of the test, and so that took a while. There was, I believe also, there was an offer for testing from other countries, which was declined. There was a lot of kind of steps. It wasn't just one thing that delayed the test result. And plus, an initial invalid test was sent out. It took a while to correct that. So it was multiple problems.
So it was, I mean, other countries like China now and Korea, you
Correct.
said, is doing, what, 20,000 a day or something?
Mm-hmm.
Okay, one last question.
And by the way, the South Korean experience was because they'd had an earlier failure with the MERS virus. They learned their lesson, and so they're better. And that is the lesson of public health. Hopefully, we'll learn this lesson and understand that we don't want to be in this situation again, and we want to be ready to go in a much, hindsight is 20/20. But I can tell you, my career has been one of everybody's concerned about it, and then massive complacency. If we forget the lessons, and then everybody's concerned. It's just this wild. We don't want that to happen again.
One last question. You mentioned that there are commercial and the CDC tests.
Yes.
What's the difference and why the difference?
Okay, so initially in West Virginia until March 7th, it was all the tests were being sent to Atlanta to the CDC. Then the CDC essentially shared those genetic probes and with the state lab. And so the state lab, as of March 7th, could do the testing in Charleston. There are commercial tests available, and Kathy Slemp, the state health officer, said on Wednesday that commercial labs, so that the test could be done at an academic, like at WVU Medicine, without having sent to Charleston. Some commercial providers of tests are probably going to come on the horizon too, again to speed up the time that we get test results.
So they've basically taken the DNA and created their own probes. Is that correct?
Correct. Yeah, it's an RNA probe. It's
or
an
RNA
virus,
probe,
yeah.
but
Yeah.
it doesn't require the CDC
No,
to give
there's
you
no,
the probe.
There's
If
no
you know the
technical reason.
technology, you can do
Correct,
this.
correct. It could be done here. It could be done in any, routine hospital lab. So there's
$64 question. How expensive is it?
that's a good question. I do not know the price. I do not know the price of the test.
Relative to, well, there is no SARS-CoV-1, right? There's no test for that yet. If I heard you correctly, is that correct?
No.
There's no vaccine for it yet.
Correct. There is a test. I'm just guessing here. It wouldn't be an inordinately expensive test.
$100 or $1,000?
Hundreds of dollars.
Okay.
It's our healthcare system, so
All right.
everything's pretty expensive.
This is the last question, not associated
Sure.
with the test.
And that's just a guess, by the way. I don't have any data.
Is there work on the SARS-CoV-1 vaccine?
No, because it isn't spreading in humans anymore. It caused that outbreak, and apart from a laboratory-acquired infection, no one was getting it, so everyone lost interest in it.
Okay. Thank you for your time. I appreciate the
Sure.
information.
Good questions.
So this question kind of builds on some of the discussion we've had as far as closures. I've just in the last couple of hours, we heard about Ohio closing their schools. There's some counties around Richmond, Virginia that are closing. My day job is at NIOSH, but I own a daycare on the side. So, we've grappled with, well, what do we do if? And then we also got word that Montgomery County, Pennsylvania has ordered all of the daycares in their area to close for 2 weeks. We were, just talking about possibly, not having services. I guess the thing that I'm wondering, though, is if we go 2 weeks, if we close 3 weeks, does that really solve the problem, or have we lulled ourselves into a place where we think everything's better, we go back to our normal business, and we really haven't made everything better? Does that?
Yeah. Okay. So I'll answer that question in two ways. At one level, as I said, with public health, we always get complacent. So you're absolutely true. That happens in the longer term. But I do think that, and we've seen this with China, that they didn't handle it well in the early phases, no question. But then when they did respond, their measures seemed to be working. So they're fairly, admittedly, draconian measures. They seem to have got the curve on at least the plateau phase. So it's absolutely true that effectively applied, reducing social gatherings can make an impact. You have to keep that up for long enough, however, and that's your question.
And that's
right?
the question
what period of time?
Right. Is 2 weeks really long enough? And then during those 2 weeks, are people going to understand that this isn't the time to go see grandma and grandpa down in, North Carolina? So, they need to really kind of shelter in place, if you will.
I think your concern is a valid one, which is essentially saying, if we do short-term closures and we begin to see things turn around, we could then reverse them and then have a surge. That's possible, yeah. Only now are some of the lockdowns in a limited way in China being lifted, and they've been under them for much more than 3 weeks. This started in early January for them.
And that's really my concern, is that, we're thinking, okay, well, if we close down a school system for 2 weeks, or if we close down a school system for 3 weeks, then magically all of, all the cases are going to magically go away. We'll go back to business as usual.
Right.
I mean, so I think, like WVU has been very prudent in really breaking off face-to-face classes throughout the rest of the semester.
Right.
So, that's my concern. I'm wondering, trying to figure out what that,
where
that balance
daycare
is.
needs to go to online. So,
I don't think the parents would appreciate that.
But a related point is the seasonality issue. Is this going to decline as the common cold and influenza do? And that's an unknown point right now. But let's hope that it does.
Yeah.
So maybe a final question, and then after the final question, what's next? We're done. Okay.
I'm wondering if anyone has been considering studies into potential immunity in those recovering from this, and if it would be durable enough to help break the spread.
Excellent question. So if you can have natural immunity, so you can have immunity through a vaccine, or you can have natural immunity from having the infection, and if you do, what duration of immunity can you expect? Again, we don't know the answer to that. Part of the problem is we're hampered by those serological tests that I mentioned we don't have. We don't have widely available tests for the antibody response that you're talking about. But based on our experience with other viruses like, common cold, et cetera, the immunity may not be, lifelong. So this may be something that wanes after 6 to 12 months, and then you become vulnerable again to the infection, unfortunately. That's what a lot of people think, but excellent question. And Marty gets the last question.
I'm actually not going to use the microphone.
Okay, I'll repeat your question.
Okay. Who should get tested? Like, if you, what symptoms, how do you know, actually, it sounds like it's a good idea for so at what point do you say, I'm going to go and get tested?
Excellent question. So the symptoms are relatively nonspecific, but again, coming back to that slide that I show you, it seems as if the combination of a high fever and a dry cough, myalgias, et cetera, right now I would still say, although bearing in mind what I said, we haven't done a lot of testing, so we don't know what the situation is like in the population. I'd be particularly concerned about people who came from other areas where we know that there is more disease. So that combination would be groups that should get tested. Bear in mind that if you're going to get tested, it's going to take a day or two to get the results, and they're going to tell you you're at home until we know the results. Because if you are concerned enough to get tested, you have to stay at home. So think about the implications of that.
Just have a cough, but no fever.
I would not get tested as things are now.
Okay. And then my other question is more specific to my personal situation. I have asthma, husband has AFib, and Emma has chronic croup. Are all of those potentially problems with this?
The Chinese study didn't look specifically at AFib. My answer to that would be no. It was coronary artery disease, so narrowing of the arteries. I might be concerned about chronic croup as a chronic lung condition, although as a child, again, they seem to be getting the less infection. They're getting the infection less readily and getting less severe cases of it. So that's on the good news front. Asthma as a chronic lung condition, not aware of any specific studies, but again, if you inferred from COPD, depending on how bad the asthma is, that might be something that poses an increased risk. Absolute question, but it cannot be an Emperor Justinian question.
I like that one. You knew more about it than I did. No, on behalf, I worked for the VA run their hospital systems for 41 years, and I still work there. And I just want to say that ever since 9/11, this is a very big word of encouragement, is that our healthcare system used to have three missions. We provided healthcare to veterans and their dependents in some ways. We also did research and education, training medical students and different nurses and whatever. But after 9/11, we came up with a fourth very, very important mission. We are the backup to the entire country, and if you've heard a lot of the things that have been said by Vice President Pence and all, the VAs will be responsible for providing healthcare services to anyone in a national emergency. And we actually, with Katrina and some of these other things, have done that.
Oh, I'm very, very grateful that you pointed that out. I did not know that, and that's very reassuring. Thank you.
Thank you so much for being here this evening, and would you offer with me thanks to Dr. Thanks to those who joined us online as well. I think we had about 43 people there who were watching online.
Those are all my relatives.
All your relatives, okay. Canadians. Thank you. Be good to yourselves and be good to your neighbors, and go in God's peace. Amen.